We always love to see patients do well, respond well, and be done with therapy in frontline treatment. But subsequent patients that subsequently do progress and go to a transplant, and then patients that after a transplant have further progression, those prove to be very challenging patients. Many of these patients are young, and it's devastating when you still have active disease after a lot of treatment. That actually has become an area which is increasingly complicated, because we used to use novel therapies in that space, but those novel therapies are now moving earlier and earlier into earlier lines of therapy. So when patients have failed transplant, they've often failed a brentuximab vedotin-containing regimen and a PD-1 containing regimen. So the first question is, how much of those drugs did the patient get, and can you utilize them in those patients that have relapsed after a transplant? And if possible, those are effective therapies that really should be used. In patients for whom they've already failed those treatments, that's where novel treatments and novel clinical trials are being tested. And those really land into, I would say, 3 buckets. One being a cellular therapy, so CAR T cells or NK cells that have been primed with antibodies. Those are being used with pretty good efficacy. New immune checkpoints are being tested, including LAG-3 targeting antibodies or bispecific antibodies targeting TIM-3 and PD-1, for example, and then other new agents entirely to see whether there can be efficacy in that population of very heavily pretreated patients. Allotransplant also remains an option, so sometimes using more traditional chemotherapy, and if you get a response, considering an allogeneic transplant is something that could be done. All told though, that's pretty unsatisfying answer to the question, because curative therapies are still a challenge in that particular space.